Hello everyone, my name is Rose and I've had the pleasure of working on this presentation with Raquel and Kristen. This presentation is on Module 1 and will provide an introduction and skills review of health policy, public health, and determinants of health while also reviewing the supplemental readings. During this presentation, we will explore key terms in health policy, go over the tools of health policy and the financial benefits, compare and contrast the role of public health in achieving longer life expectancy during the past century, and also highlighting the supplemental readings. So first I'd like to share the following key terms. There are many definitions that exist for the following terms, and I'm sure many of us have heard about them because our field is public health. However, for the purposes of this course and our text, these are the definitions we will be referring to and using during our presentation. Now let's get into several shifts that have taken place in healthcare. The 4 shifts I'd like to go over are in this image below. So let's start with the focus on disease prevention and community-targeted interventions rather than treatment. There has been a shift in focus from treating people in hospitals to keeping people healthy and treating them in the least expensive location, also known as population health, which is a term that many of us have used. As our healthcare system evolves to focus more heavily on disease prevention and community-targeted health interventions, it is important to consider the focus and the various challenges and opportunities population health presents to us. The concept of population health has led to advancements which aim to improve the health status of the community. One example is the promotion and implementation of accountable care organizations to provide incentives for healthcare providers to take responsibility for population health outcomes, which in turn has led to advancements in primary healthcare trainings and the requirement of health plans to include preventive services without cost sharing. Which leads me into the next shift, the Affordable Care Act and healthcare coverage expansion. Although improvements are still being made, the ACA fulfilled its promises by expanding health care coverage and allowed individuals to have larger selections of insurance levels and insurance company choices. Now let's go into the third shift, the role of public health and increased life expectancy in the 20th century. According to our text, by 2020, about 55 million will be older than 65 and about 23 million will be older than 75. Older individuals generally consume more health care services and are also more likely to utilize long-term care services and community health resources, which could contribute to this estimated increase in life expectancy. And lastly, there has been a positive shift in patient engagement and consumer-driven care. The supplemental readings discuss how care coordination, follow-ups, and engagement between the provider and the patient improve health outcomes. Raquel and Kristen will be discussing this later in our presentation. Now this next slide goes over how health policy affects health and the relationship they have with health determinants. Health policies affect health through an intervening set of health determinants. Health determinants in turn affect health. This figure is an example of the impact of health policies on health determinants and health. The images surrounding the figure shares different types of health determinants such as physical environment, access to care, behavioral choices, and social support. One of the supplemental readings, which we'll get into later, is how Oregon is getting frequent flyers out of the ER, which shows how organizations like Care Oregon aim to improve their community's overall health by addressing health determinants. And now I'd like to turn it over to our next presenter, Raquel, who will go over the supplemental reading on Oregon and their frequent flyers.
Hello everyone, this is Raquel and I'll be covering how Oregon is getting frequent flyers out of the ER. This was the suggested reading for this week's module. So frequent flyers are also known as heavy users of the emergency service. These patients usually have manageable chronic conditions and they regularly use the ER emergency room services as opposed to using primary care services. Mostly these patients are uninsured or they have Medicare or Medicaid recipients. And they go to the emergency departments because they don't have access to other sources of care, or they can't afford to make an appointment with a primary care doctor who can help them manage their conditions. And they have no other way of managing their health conditions in the event of a flare up, such as someone who has a heart attack and feeling a pain in their chest or something like this. Um, so, in this article, in efforts to manage the frequent flyers or heavy users, Oregon has come up with an experimental program where healthcare providers will reach out to those patients who are constantly using the ER system as a primary care. So they'll basically reach out to them and provide services and coordinate their care. So
So
in
in
this
this
article,
article,
we're
we're
introduced
introduced
to
to
40-year-old
40-year-old
um, Jermaine uh, Seals. And he states he's had a tough life and he's homeless. He sleeps in his car. And in 2011, he used the emergency room 15 times and he was admitted to the hospital 11 times. And it was in the emergency room where he met Lisa Perlenstein, who is with the Health Share of Oregon, part of the experiment of coordinating care for frequent flyers. Now, she was able to help him get new shoes, a sleeping bag, and also found a location for him, which is adult um, foster care. And by doing these things, they were able to make a bond. And further down the road, she was able to help him to go to the doctors more often and see the importance of doing this and adhering to his medications. And she was also able to get him on dialysis. And the good news with this story is his doctor also noticed an improvement in his medication adherence and his well being because now he was using a primary care doctor to treat his conditions. And as a result of the coordination care from Lisa, he went from having 15 hospital visits in 2011 down to 4 in 2012. His hospital stays also went from 11 to 4. Now, that was a great improvement and a good success story. Now, as I read this article, I was reminded of an article or basically a research study that was conducted by the World Health Organization, um, and it was titled The Social Determinants of Health. And this was a European based study which examines the health of affluent people to the health of deprived people within European countries. Now, the study was conducted, and there were 10 uh, subtopics that the study focused on, and one of the subtopics was social exclusion, and another one was social support and addiction, and these those topics tied directly into um, what this article was basically um, going over, advocating for, because it was with he went from being a homeless person, which is having poor social support and being excluded to now developing a relationship with Lisa, the care coordinator, and having access to care. And in the social determinants of health, there were policy implications for each of the subtopics. And for social exclusion, a recommendation in the article was public health policies should remove barriers to health care and social services and have affordable housing. And this directly again ties into the services that were provided by the care coordinator. Another policy intervention that was suggested by the article was intervention studies have shown that providing social support can improve patient recovery and faster rates of several different conditions. And again, in this success story with Jermaine, we see that once he received the care coordination and therefore he had improved access to health care, his health outcomes improved.
Hi, this is Kristen DeCepolo, and I'll be concluding our presentation. I'm going to talk about financial incentives and penalties that providers can experience under the Affordable Health Care Act. The first one is the Medicare Shared Savings Program for Accountable Care Organizations. You probably already know that an accountable care organization, or an ACO, are networks of physician and other providers that are held accountable for the cost and quality of the full continuum of care delivered to a group of patients. Under the Medicare Shared Savings Programs, this program will allow providers who voluntarily agree to work together to coordinate for patients and who meet certain quality standards to share in any savings they achieve for Medicare programs. ACOs which elect to become accountable for shared losses have the opportunity to share in greater savings. ACOs will coordinate and integrate Medicare services, with success being gauged by roughly 30 quality measures organized in 4 domains. These 4 domains include patient experience, care coordination and patient safety, preventative health, and at-risk populations. The higher the quality of care providers delivered, the more shared savings their accountable care organizations may earn, provided they lower the growth in healthcare expenditure. And it's estimated that they won't be responsible for more than 10% of any losses. Medical Hospital Readmission Reduction Program. This became effective October 1st, 2012. It reduces Medicare payments to hospitals by 1% who have high rates of avoidable readmissions for patients with conditions of heart attack, heart failure, or pneumonia. It is estimated that 2/3 of acute care hospitals will experience this penalty. 3 additional programs: value-based purchasing, physician quality reporting, and Medicare Advantage plan bonus. The value-based purchasing was effective October 1st, 2012. Hospitals will be rewarded for how well they perform on quality measures and for improvements in performance relative to baseline. Some of the other goals of the value-based purchasing in Medicare: financial viability. The financial viability of the traditional Medicare fee-for-service program is protected for beneficiaries and taxpayers. Payment incentives. Medicare payments are linked to the value, meaning the quality and efficiency of care. Joint accountability. Providers have joint and clinical financial accountability for healthcare in their communities. Effectiveness of care is evidence-based and outcomes-driven to better manage disease. Ensuring access. Restructured fee-for-service system provides insured access to high-quality, affordable care. Safety and transparency. Beneficiaries receive information on the quality, cost, and safety of their care. Smooth transitions. Payment systems support well-coordinated care across providers and settings. Improved technology. Electronic health records help providers deliver higher quality, efficient, and better coordinated care. The next program, the Physician Quality and Reporting, initially provided financial incentives to physicians reporting quality data to CMS through 2014. In 2015, it's required, and they've removed the incentives. And there actually may be a penalty if they don't report it. Medicare Advantage Plan bonus. Medicare provides bonuses to Medicare Advantage plans who have a 3-star. Next, I'll be discussing the healthcare frequent flyers, the treatment of Kenny Farsworth. So this is a gentleman living in the DC area who is a frequent flyer, calling 911 quite frequently, getting transported to the hospital, sometimes more than once in one day. This was a gentleman who unfortunately was on disability, was homeless, had a very small income, living place to place and not caring for himself or his medical conditions. It was discovered that he had a damaged hyoid bone eventually after many trips to the ER. He was operated on and it prepared, and a lot of his medical conditions decreased. He became less of a frequent flyer and actually started to volunteer in the community. This highlights, first of all, the need for appropriate diagnoses, but it kind of illuminates how hard it is to appropriately diagnose people when they have other things going on, such as homelessness, financial instability, and a lack of a support system, which this gentleman did. There was a firefighter involved in his case, Firefighter Cole, who would assist him with care coordination just out of the goodness of his heart, giving him clothes, shoes, money, helping him find places to take a shower. This developed the Washington Frequent Flyers program in 2008, which they try to identify people like Mr. Farsworth who may need assistance. There's other programs like Housing First. This program believes that if you don't have a place to lay your head, there's no way you're going to get any type of appropriate treatment and thrive. So this article really kind of illuminates the need for continued public health policy and also the need for care coordination, specifically developing, specifically addressing socioeconomic issues in an effort to treat the whole person. Thank you.
I'd like to thank Raquel and Kristen for preparing this presentation with me. On behalf of our group, we'd like to also thank you all for viewing our presentation and hope it was insightful to all of you. I'd like to welcome any feedback or questions we can clarify since we are the first group to present, and we'd be more than happy to follow up with you or share the questions with the professor. We all look forward to your feedback. Thank you.